So for this skill, we're going to do a blood collection from a central line. So usually the brown port is the one that you would usually pick because it's slightly larger, and as well it's most distal. So it's the farthest one inside your patient. So that's the best one for blood work. However, if you had an infusion to this line, you could of course, or if there's a reason why you can't use your brown port, you could of course use your other ports as well. But the ideal is to use your brown. So because this is locked off, we assume that there's probably heparin inside there, so we have to aspirate this heparin back first. As well, I want to make sure that I have a requisition, okay, the one that I require, as well as a blood tube, and I have a physician order. So I would verify that I have the right patient by looking at their name band, and as well compare the requisition with the name band to make sure I'm drawing the right patient's blood. Great, so once I have that all verified, as well, I would require a sticker as well to go on to my blood work. So now that I'm ready to draw my blood work, I would choose my brown port, and I'm going to swab that port 30 seconds and allow it to dry. Now I'm going to aspirate back that heparin using a 5 cc syringe. Pull back that heparin, and you can see it'll be a mixture of heparin and patient blood as well. Okay, so pull back about 5 cc discard. Okay, and then I'm going to clamp that, and I would put that into the sharps container or withdraw discard container. Okay. Now there's a few ways that you could collect your blood work. So often I would take an empty syringe and I would draw back the blood work I require. Now I'm pulling back just patient, oh, I was clamped. Now I'm just pulling back patient blood, okay? So this would be good to send to the lab. It's pure patient blood, no contaminants in it, okay? The other alternative is you can attach a vacutainer to your port. Sometimes, however, if your ports are a little bit finicky or for PICC lines, it might not work well. If I put this down, I would make sure I swab it. Okay, so you can attach your vacutainer, and then you can pop your tube on there, and you can see it fills up very nicely. Okay, and then you would just pull that off, and then twist your vacutainer off. Okay. If I chose to use the syringe method, like I just did, I would just have to transfer it now to a blood tube. So we do have the blood transfer sets. So you could attach that onto your syringe, and then you would pop your tube on the end, and it would fill, just like you just saw it filling from a vacutainer. Okay. Alternatively, if you can't find these vacutainers on your unit, you could use a blunt fill. You could attach a blunt fill, and just being very cautious, you could puncture your blood tube and allow your blood tube to fill up. Okay, so there's a few ways you could do that. So after your blood tube is filled, you would want to make sure you attach your patient label. Okay. Usually sideways like that, okay, and verify that it matches your requisition. And then you would send that off to the lab, making sure that it's filled out appropriately. Now, oh, I hadn't clamped that there. Now we want to make sure we flush our IV central line because there's blood sitting in the tubing right now, and we know that blood that sits can clot. So we would need a normal saline flush, and because I had put my line down, my cap could be contaminated because it was touching the bed, so I would make sure that I do a good swab again. Okay. And then I would attach my normal saline flush, making sure that you get all the bubbles out. Okay, and unclamp in between. And using a push pause, we want to try to clean that lumen out, make sure there's no blood sticking there. Okay, using a push pause. Then when we take that syringe off, we're going to clamp. If they look like there was still blood sitting in the cap or the tubing, I could grab another normal saline flush and I could flush again. Okay, of course you would check your facility policy. Okay, if it asks you to flush with 20 cc's, then you would follow your policy. Okay, and give another flush. Now, because there's no valves on this central line, we will need to heparinize it. So again, you would check your facility policy again, and a physician order should be present if you're going to be instilling heparin into your patient's line. Okay, and usually the order is for 200 units per line. I have way too much here. This is a 5 ml of heparin, so I'm going to squeeze some out into the med waste. Okay. So now I have 2 mLs, which is 200 units of heparin, and I would verify that with the MAR as well. Okay. I didn't put my line down, so I can connect this directly to my line. Okay. I can unclamp, okay, and I'm going to instill that. Instill that. Once I get down to the last 0.5, I want to create some positive pressure. So I'm going to push on my syringe. At the same time, I'm going to clamp right when I get at the end. So applying pressure and then clamp right away. Point is, we're trying to create some positive pressure so that the blood doesn't back up into our line. And then we would disconnect that. We would go send our blood work off, and we would also chart that we gave 200 units of heparin for line installation.